I would like to invite Erika Rutherford, Business Development Manager from NHSBT, to discuss with us issues of fetal genotyping and optimization of mother's care in this setting. Thank you very much. Over to you, Erika.
Thank you, Dora. Yes, thank you for introducing me. I'm really happy to be here. And the two previous talks were excellent, absolutely wonderful. I'm covering the background and why are we doing it and the science behind it, so don't worry about it too much, ethnic benefits and what we require and why we reject. We have been on a very long journey, starting right at the bottom in the 1990s with discovering and looking at the D gene. And to start with, we have then tested the amniotic fluid and chronosvillus sampling and genetically typed the fetus for the D gene. Later on, we did the C, E, and Kel. And so going up through the timeline, then NICE recommended that anti-D is prophylactic anti-D is wonderful. We had the fetal genotyping for mothers with antibodies then, which we could do from intravenous blood from the mother. And moving on, we then NICE recommended that we should look into a high throughput test so that we have a screening test, which we did. That was Dr. Kirsten Finnan, who developed this high throughput test, which is now called the fetal RHD screening test. We did some trials around Bristol, and then in 2015, we started to roll it out throughout the country. So to start with, we didn't test very many samples. Now we are testing loads. In the meantime, in 2016, NICE recommended the fetal RHD screening test as cost-effective. And at the moment, we are around testing in a year around 52,000 samples, which is fantastic, and hoping to get even further. So the next slide is just the NICE recommendation, which proved that it is cost-effective and a really good test to implement. And here you can see over the years how we increased from hardly anything at the bottom left to right up there where we are at the moment. When I written the slide, we were on 50K samples per annum, but we will be much further then. And we are improving our techniques and streamlining the whole process as well, so that you get a much better service and a much safer service. So why fetal genotyping? We optimize the antenatal care and giving only anti-D to women who need it. And at the fetal genotyping, the diagnostic test that is for mothers with antibodies, we continue the close monitoring of the woman and looking at the anti-D, C, E, and Kel genes, whether the baby expresses those or not. So the accuracy of the test, the fetal RHD screening test, we are aiming for less than 0.1% false negative predictions, and we are currently at 0.05% negative predictions. That is a very good outcome. That is a very accurate test. For the fetal D genotyping, we had not many reported as in false negative. For C, C, and E, we haven't had any reports, and Kel is less than 0.5% false negative predictions. You can look that up on our website. We've issued a document which states all these findings. Now coming back onto the D gene, what we do, we test the presence and the absence of the D gene. As you can see next to the D positive expressions there, which are the genes on the left-hand side. You have the D gene on the right-hand side, the C and E gene bit, which are linked together because that's why it is called RH. So you can see on the left-hand side with the positives, the D is there. Kath Philpott explained it absolutely beautifully in her talk, how it is inherited. So there you can see it. Obviously, in the middle one, you could have as well D variations where some of these black lines are not quite there, and sometimes the lab can't actually see it, whereby we genetically see it. So you might get a positive result, but serologically, because the D gene doesn't reach the cell surface, can't be detected in that way in the laboratory, only genetically. So be wary of genetic results compared to serological results. Then the outcome of our test is either D positive, D negative, or inconclusive. In the inconclusive range, that's where you often find the D variations, whereby around 70 to 80% will have the outcome of a D positive baby. So that is why you give anti-D in that case. So you give anti-D when the fetus is predicted to be D positive, and you don't give anti-D when the fetus is predicted D negative. So we are testing in the fetal RHD screening test exon 5 and 7 and have a control gene, which is CCR5. Sorry, that was in the previous slide. So this test is fully automated and is run at a low resolution, and is designed to minimize false negative results. Compared to the test for alloimmunized women, which have got antibodies, and in that case, we are testing exons 4, 5, 7, and 10 at a much higher resolution. This test is a manual test and is designed to minimize both the false negative and the false positive results. Now, as a diagram, so you do your RH and antibody screen at the booking stage. So you detect the D negative women, and you have which have no anti-D or anti-G antibodies. Then you can send the fetal RHD screening test, and then you have the two results, D positive or D negative. And D positive, you give prophylactic, you anti-D, and with the D negative women, you don't. Now, on the right-hand side, you have women which have antibodies detected. You identify, quantify, and genotype the antibody, as Kath outlined really nicely in her talk. And if the fetus is antigen positive, you monitor heavily, as your normal regime you've done. And if the fetus is negative, you do a minimum monitoring. Right, next slide. Ethnics and benefits for mothers with antibodies. The main important thing is that the clinicians, you as clinicians, can focus on women who have antigen positive fetuses, and women with antigen negative fetuses can relax and enjoy their pregnancy with minimal monitoring. This is really important because these women who have antibodies are very stressed already, and the pregnancy is it is a wonderful time, but it can be quite daunting overall. So it saves time for those women who do not need repeat clinical attendance Doppler scans, and referrals for antibody quantification and t-tests. For mothers who have the fetal RHD screen, it is really important to know that anti-D immunoglobulin is a really excellent product. But there are risks. It is a human-derived product, as said before. There are unknown agents can't be eliminated like prions, like the variant CJD. And it has a slight risk of allergic reactions, very rare to anaphylactic shock. And the failure rate is around, depending what you read on papers, 0.35 to 0.37% when given at the correct time. We suspect it might be related to the women's BMI, that they do build antibodies. And sometimes we have limited availability. We know we can't get 250 international units, 500 international units are sometimes difficult to come by these days, although they are available, but some trusts don't use them. So then we have the elimination of donor exposure if we only give anti-D to those women who need it. And samples for this test can be taken at a clinic, at a routine clinic you already have. And clinicians can focus on the women who have a predicted D-positive baby. And of course, you conserve a very expensive product, which is the anti-DIG. Now, what do you need? So the sample requirements for mothers with antibodies is for the RH, that is C, E, and D. At 16 weeks gestation, you take the blood sample, and for CAL at 20 weeks. If the outcome of that test is negative, you would have to repeat it at 28 weeks. CAL is a more complex gene than the RH genes. So these samples have to reach Filton within 3 days from venipuncture for RH, within 2 days of venipuncture for CAL. So use something like first class post with next day recorded delivery. For the fetal RHD screen, for mothers who do not have antibodies against D or G, they can have any other antibodies, but not D or G. You can take the sample from 11 weeks plus 2 days gestation, and that has to be based on the dating scan. You need only 6 ml EDTA compared to 16 ml EDTA in the diagnostic test. And it has to reach Filton within 7 days, and you can use the NHSBT logistics for transporting that to us. And that goes usually through the laboratory. For the mothers with antibodies, you use this request form, and please use our stickers. They are on the website as well. And so that we turn that around within 7 working days. For the fetal RHD screening test, you can order this request form, and that is available through our NHSBT hub. And please use our stickers again, our labeling stickers, so it is clear which samples we receive in Filton. We have reduced the turnaround time. It used to be 10 working days, but because we did a lot of continuous improvement events and testing primary samples now, we can do that because we have got the volume, and we turn it around once the sample reaches us in Filton within 1.8 days. So screening sample criteria and service. So we need the sample acceptance criteria. That is for the fetal RHD screening test, which is really important, is you can take the sample from 11.2 weeks gestation according to the dating scan. You must provide us with the EDD because that is the key identifier for the fetus. This is the only identifier we have for the fetus. For the mother, we have got 3 points of ID. Everything is secure. The fetus is just got this one identification point. The sample test, the sample needs to be tested within 7 days of venipuncture, and the mother must not have anti-D or G antibodies or a historical record of these. So we need the sample can be taken at a routine visit. The sample storage needs to be at room temperature for all genetic tests. Inconclusive results, we do not retest them because we get the same result again. So it would be a waste of time to do that. The results are available on our online system called SPIs, or SPICE, some people say. And we are in the process of rolling out the reporting and requesting and reporting via your LIMS systems. That is the laboratory management systems. And the best feature is really that these tests are really highly accurate. We only investigate false negative samples because the positive ones, they will have had anti-D. And please report all discrepancies to SHOT. Really important. So fetal RHD screening, just a recap, 1 6 ml EDTA, 1 sample only. The documentation of the test result should be made in the maternity notes, and we have a second test for mothers with antibodies. So don't forget, they are 2 very different tests with very different requirements. So some practice points. You can use butterfly needles, but they have to be in a closed system. The EDD must be from the dating scan, and send the blood to the local lab, which will forward it to us. The sample must be room temperature storage, not in the fridge. This is so different from other samples, so that it is really, sometimes a mistake is made easily. Blood samples have to be directly into a closed system. Yes, I did say that. Okay, routine anti-D prophylaxis is offered at 28 weeks to those women who have a predicted fetal D positive or inconclusive result. Right, now we get to the bit where, why do we reject these samples? So we have 3 very large areas. One is sample discrepancy. So as soon as we get the requesting and reporting all rolled out to everybody, this will always be there. It is a human error, but with electronic solutions, we might reduce that. The other huge category is EDD, which means basically that either it hasn't been written on the form, or the wrong year is put. It's mainly, it sometimes starts already in August when we get an EDD in the past. We had quality incidences where we corrected it before, so we can't do that anymore because we had I think it was 1 or 2 corrections where we corrected the year, and the EDD was completely wrong. So we can't do that. Then we have obviously insufficient samples, which please watch out that these 6 ml tubes are filled to the top. And then we often have at the top, left-hand side, around 10 to 11 o'clock, if you see it as a clock, is that samples have already been tested or they have either D or T antibodies. Then why should samples arrive at the earlier stage? The earlier, the fresher the sample is, the better the quality of the sample is. Basically, that's what it comes down to. So get that sample as quickly as possible to the lab, and the lab will send it with the next available NHSBT transport. And it is really, really important to get it to us as soon as possible. And we are working on Saturdays now. So send the samples on the Friday if you can, and see that they get to us ASAP. Just a few points, which is my last slide really. The EDD is the only identifier for the fetus and the pregnancy. Please ensure that you check the EDD when looking at app results, because we have had it that people looked up the wrong pregnancy and the wrong fetus. And have a look at our question and answer document on the website. It is a very helpful document. I collated that from all your questions and gave official answers to your questions in that document. If you can't find the answer to your question, please email me and I will provide you with an answer. When the baby is born, you will know the D group of the baby, and you can have your anti-D ready right there and then. So, any questions? And my lovely son and my granddaughter. Thank you, and I stop sharing.
Thank you, Erika.